Hi everybody, my name is Jimena Chavez, my teacher is John Moscoso. I'm studying on Catholic University Nursing School, San Vicente of Paul. My topic is acute osteomyelitis in children. Okay, it is a bone infection is caused by bacteria or other microorganisms. The site of infection usually located in tubular bone above vessels are metaphyseal which commonly suffer from the initial impact. That is a first video of the topic.
Osteomyelitis can be thought of simply as a bone infection. Osteomyelitis occurs when microorganisms, usually bacteria, are able to grow in bone and bone marrow. There are two ways that the microorganisms can be introduced into the bone. The first way is through an open wound. The open wound may occur with an injury, such as an open fracture. There are bacteria everywhere. If bone is exposed to dirt, water, or even air, microorganisms may seed to the bone, begin to grow, and cause an infection. Bone may also be exposed to microorganisms in open sores and overlying soft tissue infections. People with diabetes often have sores on their feet that can become infected. Orthopedic implants such as plates, screws, and knee replacement prostheses make good places for bacteria to grow. The second way that osteomyelitis occurs is when microorganisms travel through the blood until they are able to settle in the bone. This is known as hematogenous infection. Often, this occurs because bacteria from another infection in the body travel through the bloodstream to the bone. Whatever the cause and whatever the source, the infection can begin to eat away at the bone. This can result in pain, loss of function, a collection of pus known as an abscess, and dead bone. Osteomyelitis is not usually visible on x-rays for several days after it begins. It will show up earlier on MRIs or bone scans. Blood work is also important. The white blood cell count is usually high. Lab values known as the erythrocyte sedimentation rate or SED rate and the CRP, C-reactive protein, are usually obtained when osteomyelitis is suspected. If they are high, it raises the doctor's suspicion of infection. These lab values are monitored as the infection is treated. If they drop, it is an indication that the treatment is working. Treatment depends on what bone is involved, where the infection is located, whether an abscess or dead bone is present, the age of the patient, and other factors. Treatment often involves surgery to remove infected bone and soft tissue. The affected area is thoroughly irrigated to wash away the bacteria and pus. The infected bone is then sent to the lab for analysis. Within a few days, the bacteria can be grown in a culture in the lab and tested with different antibiotics to see which antibiotics are most effective at killing it. While the doctors wait for these culture and sensitivity results, they can only make an educated guess as to which antibiotics will be best. This is known as empirical treatment. They make this guess based on what types of organisms have caused similar infections in similar patients. These antibiotics are usually given through an IV. IV antibiotics are often necessary for several weeks after the infection is discovered.
Okay, it was a video, and continue with the exposition. We have the symptoms. The symptoms is bone pain, excessive sweating, fever, and chills, general discomfort, uneasiness, or ill feeling, local swelling, redness, and warm, pain at the site of infection, swelling of the ankles, feet, and legs. There is other video. Let's see.
Good morning. I'm Sandy Goff. We're going to talk about bone infections today, and I'm going to try and lecture a little bit loosely off of my slides. so you guys can ask questions. Some of you have heard this talk before, but fear not, repetition is good for you. So let's go ahead and get started. Divide us into categories. It makes it easier to remember and helps you figure out what to do with them. The first one is hematogenous osteomyelitis. It usually occurs in long bones, thank you, and is treated with intravenous antibiotics, or excuse me, is also IV drug users may get hematogenous osteo, and you can also have discitis or vertebral osteomyelitis of hematogenous origin. You also can have contiguous focus osteomyelitis from the outside going in, usually related to either trauma in the setting of neovascular disease or in the setting of vascular disease related to ischemia and tissue breakdown. And also there's chronic osteomyelitis, and usually that involves necrotic bone. We'll talk about that a little bit further. The key features to be aware of in bone infections is that they occur in areas of avascular bone. And certainly any area where you've had preceding trauma, any fracture with scar or inflammation, arthritis, mostly just devascularized bone. Bone, as you know, doesn't have a whole lot of good vasculature to begin with. Areas of thrombosis or ischemia again. Usually you require prolonged antibiotics to get bone infections under control, and they usually require debridement of that the dead bone and avascular areas. Hematogenous osteo is commonest in children. In adults, it usually is in those areas of abnormal bone. Transient bacteremia usually will inoculate the bone, and then from there it will spread either locally or through the Vulcan and Haversian canals if you go back to your Anatomy 101. And you can develop septic joints. Periosteal lifting, which is usually seen in children because their periosteum isn't stuck down as it is in adults. Sinus tracts may appear as a late effect, and you can also see metaphyseal edema and abscesses in the metaphysis, like as an Brody's abscess. So here's a couple schematics of the anatomy, and you'll see the little end arteries. Thank you very much. Sorry, technical malfunction here. Little end arteries where you have sluggish flow. The bone marrow obviously is where you have the most vascularity, and then there's a growth plate with osteoblastic activity. Usually the infections in adults in particular don't cross that area. And in hematogenous osteo, again, there's that avascular growth plate, and you don't usually get infected joints related to hematogenous osteo unless you have an unusual attachment of the ligaments, and it's able to cross the tissue planes there. Septic arthritis most commonly will occur at the elbow with the proximal radius, at the shoulder and the humeral head, and in the femoral head and the hip. In infants, you most often see Staphylococcus aureus, particularly now with community-acquired MRSA. You can also see Group B strep or E. coli. In young children to teens, usually, again, it's going to be Staphylococcus aureus, sometimes Group A strep. And in adults, it's usually Staphylococcus aureus. These are some plain films. You may not be able to see these very well, but this little lucency at the metaphysis of a long bone is Brody's abscess.
Okay. And we have exam and test. Blood cultures, bone biopsy, a sample is cultured and examined under a microscope. Bone scan, bone radiography, complete blood count, selected protein, MRI of bone, needle aspiration of the area affect bones. Let's see other video about the topic.
Osteomyelitis by Foon Nguyen and Seth Swanson. Osteomyelitis is an inflammation of the bone and/or bone marrow. The most common causes are by microbial infection that reaches the bone through abscessed teeth, periodontal lesions, post-surgical infection, or traumatic injuries. Osteomyelitis can be classified as either acute or chronic based on the differences in the host response and the causative agent. Signs and symptoms for acute osteomyelitis include pain, paresthesia of the lower lip, lymphadenopathy, purulent exudate, and a fetid oral odor. Swelling and fever can also occur. Teeth in the affected region may be mobile.
Chronic osteomyelitis generally has a less severe symptoms and longer history than the acute form. Signs and symptoms include mild to moderate pain, lymphadenopathy, sinus tract formation, recurrent swelling, variable fever, and loose teeth. On the right is an example of an intraoral draining sinus associated with chronic osteomyelitis. Osteomyelitis is a rare disease with an incidence of 25 in 100,000. There's a high prevalence in males, particularly in the 50s to 60s. People who are at an increased risk include those who have undergone radiotherapy and the immunosuppression. The trabeculation pattern has a loss of sharpness. Sequestra may be present, which are necrotic pieces of bone. They appear as islands of non-vital radiopaque bone surrounded by a region of radiolucent bone. The chronic form is also mixed with mostly a radiopaque or sclerotic bone pattern. Sequestra are more common in chronic. Computed tomography is the best imaging technique to visualize internal structures in sequestra. On the right is a CT scan of a sequestrum in the mandible.
For other structures, acute osteomyelitis may lead to bone formation or bone resorption. The cortical bone is often resorbed. The periosteum may be lifted by an inflammatory exudate which stimulates bone formation adjacent to the bone surface, leading to an onion skin appearance, which is also called proliferative periostitis. On the right, the white arrows indicate a proliferative periostitis in the mandible.
Formation of new periosteal bone is often associated with chronic osteomyelitis. The radiographic proliferative periostitis may also be seen. Teeth in the affected region may undergo external resorption along the whole surface. Draining fistula may develop, which appears as a break in the cortical bone. The lesions for both forms of osteomyelitis can be single or multiple. The size of the osteomyelitic lesions can also be variable.
For treatment, the primary objective of the treatment of acute osteomyelitis is to remove the source of inflammation. Antibiotics are recommended along with the establishment of a drainage pathway. Tooth extraction, incision and drainage, or root canal therapy may be indicated as an appropriate treatment.
Chronic osteomyelitis is often more difficult to treat than the acute form. Surgical interventions such as sequestrectomy, decortication, and resection may be indicated. The type of surgery depends on the extent of the lesion, with elimination of all infected and necrotic tissues as the goal. Use of hyperbaric oxygen is also advocated, especially in the irradiated mandible. The picture below is a case of chronic osteomyelitis in an elderly man. Sequestrectomy was done to retrieve the sequestrum that is shown on the right.
The differential diagnosis for acute osteomyelitis includes fibrous dysplasia and malignant neoplasia. Malignant neoplasia includes osteosarcoma. Fibrous dysplasia can have a radiographic presentation of mixed radiolucent radiopaque similar to osteomyelitis. Malignant neoplasia can have an ill-defined border and a mixed internal structure. The differential diagnosis for chronic osteomyelitis includes Paget's disease of bone, fibrous dysplasia, and osteosarcoma. Osteosarcoma and fibrous dysplasia are included for the same reasons as acute osteomyelitis. Paget's disease of bone can result in expansion of the mandible and can have a mixed radiolucent radiopaque cotton wool appearance.
Okay, continue with the exposition. We have the treatment. The goal of treatment is to eliminate the infection and reduce damage to the bone and surrounding tissues. Antibiotics are given to kill the bacteria that are causing the infection. Surgery may be needed to remove net bone tissue if you have an infection that will not go away.
descriptions for an inflammation of the bone. Nevertheless, osteitis is becoming more and more the term used and accepted. The cause of an inflammation of the bone can come from outside, exogenous factors, or from inside, endogenous factors. When both factors occur at the same time, then we speak of combined forms. The so-called idiopathic factors may also be regarded as a fourth form, consisting of bone inflammations of unidentifiable origin. Exogenous factors include, for example, numerous bacteria, viruses, and fungi. They are potential pathogenic agents. If these pathogens find their way into our body, they cause an inflammation. If the inflammation gets into the bone, then of course it's a bone inflammation. In the case of endogenous factors, the cause lies in our own bodies. For example, in the case of diabetics, the raised level of sugar of a diabetic leads to ever-increasing thickening of the walls of the blood vessels, and thus an ever poorer flow of blood. In some cases, the flow of blood can get so bad that certain areas of the body are no longer reached by it at all anymore, and the affected tissues die due to a lack of oxygen, and will be destroyed as a consequence of an inflammatory reaction. This can also occur in the bones, as shown in the animation, and that would be an example of an endogenous osteomyelitis. Idiopathic osteomyelitis means to the patient that, at the end of the day, the doctor cannot find an adequate explanation for it. In the jaw area, the most common causes of bone inflammation are exogenous, or more accurately, iatrogenous, meaning caused by the doctor. Thus, often extractions and/or badly root-treated teeth lead to bone infections. In the picture, you see an X-ray of an extraction wound. Here, circled in blue, the bone in this area is inflamed. Circled in red, that's osteomyelitis. In order to diagnose osteomyelitis, an X-ray is usually required. In the same picture, you can see a tooth, circled in green, which has an inflammation of the bone going on at the tip of the root, circled in red. We can tell this from the dark spot. X-rays can provide a lot of information about the bone, but if precision is needed, then a CT or MRT scan is very useful. This brings us to the diagnosis, where we seem to be concentrated in the areas with raised bone metabolism after being applied intravenously. This increased concentration can be seen from the outside by means of a special camera, the darker spots in the exposure. Unfortunately, it is not possible with this method to distinguish between the different causes of the raised bone metabolism. Is the cause an inflammation, or only an innocent buildup of bone after all? But with the addition of special factors, such as marked antigranulocyte antibodies, for additional investigation, the examination can be made more specific. Blood tests are likewise not specific, and unfortunately the blood values of the inflammation do not always correlate with the values of the osteomyelitis, especially in the jaw area. A bone biopsy is usually the most reliable means of diagnosis, as this way the bone can be viewed very precisely under a microscope, known as a histological examination. It may even be possible to isolate the offending pathogen on the culture glass via bacteriology. If this succeeds, then an antibiogram can be carried out in order to find the antibiotic with which to destroy the pathogen. However, biopsy has some disadvantages. The examination is invasive, therefore a wound is unavoidable. And not all areas of the bone can be biopsied easily. Sometimes the bacteriological investigations are not successful. Or when taking the sample, there may be contamination, for example by non-specific bacteria from the mouth. Now, let's take a look at the treatment options for osteomyelitis. There are various possibilities available. In the worst case, the affected bone must be removed, but this is very seldom necessary. The most frequent and simplest treatment option is the prescription of antibiotics, which can be swallowed or applied intravenously. The latter option gives a higher concentration of the active ingredient in the blood. By using oxygen therapy, we can enrich the concentration of oxygen in the blood, since within the inflamed bone there is frequently insufficient blood supply and consequently too little oxygen. These are ideal conditions for the multiplication of bacteria which do not tolerate oxygen, anaerobic bacteria, as they are known. Oxygen-rich blood should have an effect on these bacteria, as per the saying, a little blood but very rich. Another much talked about treatment is the removal of the sick bone and the filling of the resultant gap with replacement donor bone, which has been enriched with an antibiotic. In the animation, you can see how the donor bone with the antibiotic, shown here in green, is put in place. The inflamed bone, shown in red here, will be removed and the donor bone will be inserted in the resulting cavity. The antibiotic will then pass continually into the body over months, and simultaneously the replacement bone can regenerate. The advantage of this treatment is that far higher concentrations of medication can be placed specifically in the affected area, unlike with the usual means of application, such as orally or intravenously. Examination over a long period of time is still needed in order to evaluate this treatment over several years. Ideally, you want to avoid it getting to that stage, of course. At least the iatrogenic forms of osteomyelitis can be avoided through sterilization and cleanliness in the dental clinic. You can see more about this topic in the video Sterilization and Disposable Covers.
Okay. So we have the expectations. With treatment, the outcome for acute osteomyelitis is usually good. The outlook is worse for those with long osteomyelitis chronic. Symptoms may come and go for years. Even with surgery, amputation may be required, especially in people with diabetes or poor circulation. Then we have other video about the treatment. Okay. Then finally we have the conclusion. Osteomyelitis is a disease that causes destruction of bone tissue and is produced primarily by pathogenic bacteria, although there are other microorganisms responsible in certain circumstances. It presents a series of signs and symptoms that include general manifestation and local has fever and malaise, severe pain in the affected area. Overall, osteomyelitis is a rare condition in a territory maxillofacial, taking into account the large number of traumatic injuries and infection dental origin. But it may occur in the clinic, so it's vital now its manifestation and treatment option in order to diagnose, give timely and appropriate treatment. Okay, that's it, and thank you.